Starting our conversation about the kidney, our first lab biomarker is blood urea nitrogen. And we're going to look at some other kidney biomarkers further and in more depth when we get to our section on kidneys and urinalysis in a few weeks. But blood urea nitrogen levels are related to metabolic function of the liver, renal blood flow, and the excretory function of the kidney. The liver forms urea as an end product of protein metabolism, and we can kind of see the breakdown here. Proteins get broken down to amino acids, which then get broken down into NH3, which get converted into urea using the urea cycle. That then goes into general circulation, gets filtered through the kidneys, and ultimately excreted as urea in the urine. So we can measure this value of blood urea nitrogen. Of essentially what is the urea, the nitrogen load in the blood currently. We can see in adults, we're looking at a range of 6 to 20, and the ranges vary based off of age and stage. Optimum is 10 to 18, and critical value, which would indicate a really severe renal impairment, is over 50. Now, azotemia is increased blood urea nitrogen or increased BUN. Now we can identify then where is this happening? Is it pre-renal, which is the most common cause of increased blood urea nitrogen? And in this case, kidneys do not need to be diseased to have this elevation. You'll see this occurs as a decreased renal blood flow, which leads to decreased renal excretion, leading to retention of blood urea nitrogen, and that will lead to an increase in the serum and the plasma. If we had renal azotemia, that would consider, or we would consider kidney disease or damage because it's a problem in the kidney itself, and that's leading to a decreased excretion capability, and that leads to an increase in blood urea nitrogen in the serum. Or it could be a post-renal azotemia, which would be obstruction. And this is often due to ureter obstruction from kidney stones, but it could even be all the way down in the bladder neck from benign prostatic hyperplasia, as seen here. You could see then decreased urine excretion, regurgitation back of BUN into the blood, and the vessels will cause then increased BUN and serum. This is again showing the three different areas that could potentially cause acute renal failure. And if you saw these, that could lead to azotemia, increased BUN. If we see decreased levels of BUN, we're looking at liver failure because we're not maybe capable of making urea effectively. Something's wrong in the liver that is affecting the urea cycle. Overhydration or negative nitrogen balance, maybe now malnutrition or starvation. It's typically late stages. Early pregnancy due to dilution from water or BUN dilution and nephrotic syndrome. And this is often due to protein loss, gross protein loss through the kidneys. Interfering factors are changes in dietary intake from protein, as well as changes in muscle mass, pregnancy, overhydration or dehydration, and certain medications. Another measure of kidney function is creatinine. This is produced from metabolism of creatine phosphate, which is located in muscle tissue. If you remember, creatine phosphate is one of our fast ways to access ATP, adenosine triphosphate, for energy. There's really little daily fluctuation because muscle mass in the body is typically stable. There is kind of a diurnal variation. It's lower in the morning and higher in the evening. And creatinine is 100% excreted in the kidneys. So it's a really useful test to evaluate kidney function and glomerular filtration rate, or GFR. Our hepatic function or liver function does not typically affect values. So it's a great way to also separate out kidney versus liver cause for those emunctory organs or organs of excretion. The levels will rise later on the BUN in renal disease, and if creatinine doubled, for instance, that suggests a 50% decrease in filtration. So some causes of increased levels would be renal or kidney disease, acromegaly, rhabdomyolysis, breakdown of muscle, muscular dystrophy or myasthenia gravis, obstruction of the urinary tree, or a high protein, specifically high meat diet. So carnivore diet individuals, this would be something we need to monitor for them. Decreased levels would be decreased muscle mass, inadequate protein intake, and a smaller stature. Some interfering factors, again, a high meat diet, a carnivore diet would cause a transient elevation. Higher levels of ascorbic acid and cephalosporin antibiotics could falsely increase levels. Even ketoacidosis, so the ketogenic diet can increase, and then specific drugs. Here are your levels. They do have them separated out by gender assigned at birth. So adult males or AMAB individuals, zero point 0.8 to 1.3 versus adult females or AFAB individuals, zero point 0.6 to 1.1. And this is based off of muscle mass. So we can also kind of keep that in mind when evaluating and interpreting these values. We can then take these two variables and we can create a ratio to look at kidney function. 10 to 1 BUN to creatinine is about normal. If it's greater than 20 per 1, we consider that pre-renal azotemia when the BUN is really elevated compared to the creatinine. A 10 to 1 ratio, which is normal, could be renal azotemia, where BUN and creatinine rise in proportion to one another. And then a 10 to 1 ratio could also indicate post-renal azotemia. There could be a decreased ratio where BUN is closer to creatinine if there's liver disease. So, liver disease, overhydration, syndrome of inappropriate antidiuretic hormone, or even pregnancy. We'll stop here. When we come back, we're going to look at protein and how we can measure this in the blood.